I'm going to turn the floor over to Dr. John Cavalli and Megan Chenoweth to tell us about the SBE CCC. John and Megan, the floor is yours.
Thanks so much, Lynette. So we're going to go ahead and pull up the slides here. Can everybody see this okay? Or I guess you can't respond to me, so if you want to throw a thumbs up. Oh, perfect. Thank you. Thank you for that really nice introduction, Lynette. As she mentioned, I'm John Cavalli. I'm faculty at ICPSR, and I'm the project director for this coordinating center. And we're really excited to talk to you all a bit about the Social Behavior and Economic COVID Consortium and some of the preliminary findings from the first year. Go to the next slide. Before we start talking about some of the research that our members have been doing in this first year, I wanted to give you guys just kind of a quick, very broad overview of the coordinating center, starting with an introduction to the coordinating center staff. So we have Maggie Levenstein, who is the principal investigator. As I mentioned, I'm the project director. We have Amy Pienta and Jim McNally, who are co-investigators, and then Megan Chenoweth is our fantastic project manager, who you will hear from quite shortly. Next slide, thanks. So the Coordinating Center has 5 primary aims. We support collaboration among consortium members and the broader research community, including by working to establish common data elements for social, behavioral, and economic research on COVID. We also disseminate and publicize our consortium members' findings through social media and other avenues. We provide a broad range of guidance to support in areas like data sharing, data archiving, but also methodological consultation with some of our partners and other parts of the Institute for Social Research that specialize in survey methodology and survey research, and much, much more. We also provide pilot grants to promote collaboration and try to foster new relationships within the consortium, between consortium members and with external researchers. And then finally, we hold a yearly meeting. We actually just held our first one a week or two ago for consortium members to share and discuss findings with each other and with the National Institutes of Health. So with that quick 30,000-foot view of the coordinating center, I want to dive into kind of the meat of our presentation, which is some of the preliminary research that our members have been doing. And to start, we're going to be looking at those groups who are studying COVID-19 public health policies and their impacts. So first, we have Bruce Weinberg's group at The Ohio State University. And Bruce has been doing some really interesting work developing a model to explore the effect of various policy combinations on COVID-19 cases, mortality, and the economic ramifications of that. This model will help to identify which policy combinations are the most promote the most ideal health and economic outcomes. And I think what I find most interesting is that it actually provides a really robust comparison that allows us to quantify the costs, both economic and in the health realm, from deviating from such optimal policies. Next slide. And so they've been doing a lot of hard work in kind of getting this model off the ground. And while the initial results from this model are not yet available, though stay tuned, they should be out in the coming months. Bruce's group has already published some other work on the economic ramifications of the COVID-19 pandemic. Here is just a figure from a recent paper they had in the journal Demography, where they looked at the economic ramifications of the COVID pandemic compared to some previous recessions that we've seen in the US. Move on to the next slide. So our next researcher, we have Rita Hamad's group at the University of California, San Francisco. And Dr. Hamad's group has done some really amazing work creating a database of county-level COVID-19 policies, which they're using to assess the impact of various policies on health disparities, specifically those that are related to mental health and healthcare utilization. Thank you. This data set includes over 300 counties and represents more than half of the US population. It's diverse with respect to geography, race, ethnicity, and urbanicity. And data collected data were collected for 2020 and 2021. And they did a really fantastic job of doing the legwork of combing through government websites, press releases, and many other data sources to ensure that their data were as complete as possible. And I mentioned that because I think probably the most exciting aspect of this, beyond the results that should be coming out very soon, is that we're currently working with RITA to archive her data so that it will become publicly available. So again, stay tuned for that, because that should be coming soon. Next slide. So next, we also have Shannon Monet's group at Syracuse University, who is exploring how state COVID-19 policies may have impacted adult mental health outcomes. And so they do this in a few different ways, but they're, I think, one of the most interesting things to me is that they're applying a Bayesian group index model approach. And that helps account for some of the complex interrelations between policies that were frequently implemented simultaneously. One of the biggest challenges for studying these policies is that they're not done one at a time as we would like them to be for an easy regression model. And so their approach takes that into account. And to do this, Shannon's group has developed the National Wellbeing Survey, which is a representative survey of working age adults in the US that they'll collect annually through 2025. Shannon is also one of our year one pilot grant recipients, which I'll talk about towards the end of the presentation. And as you can see kind of towards the bottom of the slide, she used her pilot grant to essentially double the size of her year two survey, going from around 4,000 participants to around 8,000 participants. So just kind of to illustrate some of the ways that the pilot grant program is supporting research in the consortium. Next slide. So our last group in this area is actually one of our more recent additions. They just joined, I believe, in July or August. And this is led by Elaine Hill at the University of Rochester and Meredith Adams at Wake Forest. And they're aiming to explore how the COVID-19 pandemic has exacerbated social vulnerability and how this affected prevalence of opioid use disorder and related harms. Next slide. They're using a variety of data sources to look at this, including mortality data from the National Center for Health Statistics at CDC, variety of claims data and electronic health records from the National COVID Cohort Collaborative. And we're really excited to see where they take this research, and they've already kind of hit the ground running. So with that, I'm going to turn things over to Megan, who's going to talk about some consortium members who are studying pandemic-related inequity.
Great. Thank you, John. So one of the key goals of our consortium is to look at the ways in which COVID-19 pandemic has exacerbated disparities based on race, ethnicity, socioeconomic status, gender, and other demographic considerations. So we have several consortium members who are examining pandemic-related inequity and how it affects a variety of outcomes, specifically related to mortality, mental health, education, and neighborhoods. One of our projects that is looking at this is led by Raj Chetty of Harvard University and by co-investigator Michael Stepner of the University of Toronto. Dr. Chetty and his team are building a database of mortality rates by age, income, race, ethnicity, and gender in the United States for the period 2000 through 2020. They're building the database by linking data from anonymized tax records, census records, and mortality records from the Social Security Administration. And they're using their database to examine racial gaps in life expectancy, but also how those gaps vary by income and how the relationship between race, income, and mortality has changed over time. And they're also focused on identifying differences in mortality rates by race and income during the COVID-19 pandemic. Dr. Chetty's team has found that between 2000 and 2019, race-based discrepancies in life expectancy diminished to the point where they were nearly gone by 2019 when factoring in differences in income. So we're not saying there are no race-based discrepancies. We're saying that life expectancy does differ by race, but that difference disappears when you control for income differences as well. But then in 2020, they found that the pandemic changed this. And starting in 2020, they again observed a difference in life expectancy between Black and white men, even when controlling for income. Our next consortium member examining pandemic-related inequities is Clarke and Ann Meyer of the University of Minnesota. They're looking at differences in time spent by men and women on paid work, housework, and childcare during the COVID-19 pandemic, and then how that varies between different gender couples versus same gender couples. They're also looking at how these sources of stress are associated with anxiety and depressive symptoms. Their project uses data from their National Couples Health and Time Study, or NCHAT, which collects data from married and cohabiting couples between the ages of 20 and 60 in the United States. And NCHAT oversamples same-gender couples and sexual minorities. Data from Wave 1 of the NCHAT study is curated and available through ICPSR already, including both public use and restricted versions of the data. And in fact, if you joined Dr. Levenstein's overview of the state of the consortium earlier this week, you may have noticed that Dr. Kampdush and Dr. Meyer were awarded, Dr. Kampdush and her other co-investigator were awarded the Piper Simmons Award for this study, which is now available through ICPSR. One particularly interesting finding from their recent work is the association between gender, partner's gender, and discrepancies in time spent on different tasks during the pandemic. So, for example, compared to men in different gender couples, women in different gender couples spent more time on childcare, as did both men and women in same gender couples. Women in different gender couples also spent more time on housework than men in different gender couples, but there was not that difference between men and women in same gender couples. And then finally, women in both different and same gender couples spent less time on paid work than men in different gender couples. Our consortium members, Brian Elbel and Amy Schwartz, are looking at pandemic-related inequities among school-age children in New York City. They are investigating the effects of the pandemic on children's health and learning outcomes. And they're also exploring how vaccination at both the child level and community level mitigates effects on health and learning. So in other words, do children's outcomes improve when they themselves are vaccinated? Do they improve when more people in the community around them are vaccinated? And they're also looking at the ways in which neighborhood resources mitigate those outcomes as well. And they're using data from the New York City Student Population Health Registry. Dr. Elbel and Dr. Schwartz started by looking at vaccination rates at the school level, broken down by school majority race and geography. So you can see variation here, both by majority race of the school, with majority Asian schools having the highest vaccination rates and majority Black and Hispanic having the lowest. And you can also see variation by New York City borough. Their work with child level data, which is in progress, is showing similar discrepancies. And then lastly, a project led by Philippa Clarke and Grace Noppert explores how the pandemic exacerbated pre-existing social inequalities across neighborhoods within the United States. So for example, which communities have become more or less disadvantaged during the pandemic, which communities have experienced the most permanent business closures, that sort of question. Dr. Clarke and Dr. Noppert run the National Neighborhood Data Archive, or NANDA, which contains nationwide measures of the physical and social environment starting from the year 2000. They'll be augmenting their data with new and updated measures from the period during the pandemic. This is one of our newer projects. They're just getting started, so their work is still in progress, but they have been running NANDA for a few years now. So we'll tell you a little more about that. as I said, this is a publicly available data archive. It contains contextual measures describing neighborhoods across the United States with data available starting from about 2000 through currently about 2018. NANDA has, it offers theoretically derived, spatially referenced nationwide measures of the physical and social environment. And it was created with the intent of sharing data on neighborhood characteristics, reducing effort across projects and promoting consistency across projects by ensuring that contextual measures are being created in similar ways and used consistently across projects. And so that the idea is this data is completely free. Anybody with research questions that address place can download NANDA contextual measures and then link them with other data sources that, that they're working with, survey data, electronic medical records, or whatever microdata they're working with. So we also have several consortium members who are focused on how the COVID-19 pandemic has affected the healthcare system. Our consortium members are looking at the effects of new delivery modes like telehealth. They're looking at disruptions in diagnosis and treatment of chronic conditions. And they're looking at new methods for estimating community transmission and spread of COVID-19. Our consortium member, Cameron Kaplan of the University of Southern California, is interested in disparities in outpatient care and use of televisits among patients with one of two common chronic conditions, hypertension or diabetes. Dr. Kaplan is asking whether the pandemic has led to racial and ethnic disparities in routine care for these conditions. And he's comparing a large urban safety net health system to the commercially insured population. His study is a mixed methods study, which entails both quantitative data, such as Optum Medicare claims data and data from the Los Angeles County Health Department. He also uses qualitative data in the form of conducting interviews with health system leaders, healthcare providers, and patients. Dr. Kaplan's data from the commercially insured population has shown that average monthly outpatient visit rates dropped from about 30% each month pre-pandemic to about 25% following the pandemic. So in other words, before the pandemic, patients had about a 30% chance of seeing a doctor for one of these conditions in any given month, and that chance dropped to 25% in any given month post-COVID. Dr. Kaplan also observed that that all racial and ethnic groups experienced a similar drop of about 4.9 percentage points, with the exception of Black patients who actually experienced only a slightly smaller percentage point drop. And again, this is looking at specifically the commercially insured population. Another of our consortium members, John Hsu of Harvard Medical School, is focused on the ways in which the strains experienced by the healthcare system during the pandemic affected their ability to diagnose and treat Alzheimer's disease and Alzheimer's disease-related dementias. He's looking at the impact of healthcare delivery mode, so for example, switching to telehealth, on the quality of diagnoses made for these conditions and data collected during visits. He's looking at whether changes in healthcare delivery mode resulted in more clinical events later, and he's looking at whether hospitals being at or over capacity resulted in more deaths or readmissions. Dr. Hsu has shown some preliminary data on the various ways in which the pandemic changed healthcare delivery and capacity. So for example, his data from the Massachusetts General Brigham Health System showed really sharp shifts in visit mode to telehealth starting in March 2020. And then his future research will examine the downstream effects of these factors in the healthcare system's ability to diagnose and treat Alzheimer's disease and Alzheimer's disease-related dementias in these circumstances. Another consortium member examining how shifts in healthcare have affected patient care for chronic conditions is Karen Joint-Maddox of Washington University School of Medicine in St. Louis. Dr. Joint-Maddox is interested in the spillover effects of COVID-19, the ways in which shifts in healthcare delivery during the pandemic have disrupted routine care for specifically for cardiovascular disease. In particular, her research is looking at discrepancies in spillover effects between rural and urban areas, and she's using Medicare data for her study. Dr. Joint-Maddox just joined the consortium earlier this year, and she's still getting started with her work. But here's just a glimpse of what she's working on. She aims to quantify the spillover effects of COVID during the pandemic. So, for example, how much did the pandemic cause deferrals of doctor visits? How much did it affect inpatient care within the hospital? And she's looking to characterize the mitigation strategies used to counter spillover effects as well. And she also wants to quantify the short and long-term effects of both disruptions in acute care and deferral of chronic care. Again, looking at the differences between rural and urban areas. Finally, we have Yajwan Si of the University of Michigan Institute for Social Research, who is trying to improve estimates of community infection rates and immunity status for COVID-19. Dr. Si has noted that the measures we use for community transmission rates and immunity both do not come from a representative sample. So our measures for community transmission, for example, generally comes from test data of symptomatic individuals. Our measure of immunity, we usually vaccination status stands in for community immunity, but that of course leaves out the effects of immunity acquired by actually getting COVID. So, and also vaccination rates vary by race and ethnicity in ways that naturally acquired immunity doesn't. So Dr. Si's approach addresses this by using PCR tests and antibody immunity data from asymptomatic preoperative patients admitted to hospitals. And she and her co-investigators are using a statistical technique called multi-level regression and post-stratification, or MR-P, to more accurately predict both transmission and immunity rates. And Dr. Si's preliminary work has shown that the model she is developing using MR-P is a pretty good predictor of emergency room visits. In addition to their main projects, Dr. Si and Dr. Kaplan are collaborating on a pilot project. They're using Dr. Kaplan's data on hospital admissions in the LA County Health Department hospital system to validate Dr. Si's measure of community transmission using asymptomatic PCR tests administered ahead of hospital procedures. The demographics of patients at LA County Hospital differ from the population where the measure was originally developed. So this pilot grant collaboration gives them an opportunity to examine how social determinants of health produce disparities in positivity rate among different racial and ethnic groups. So those are our 12 consortium members. We are actually expecting our consortium to grow a little bit, with 3 new members being awarded this month. So please keep an eye on our website or follow ICPSR on Twitter to learn more about them. And with that, I will turn things back over to John.
Yeah, thanks, Megan. So just before we wrap things up today, I wanted to talk a little bit about the Year 2 pilot grants, which the request for proposals went out just a couple weeks ago. If you go to the next slide, Megan. And so just kind of as a quick reminder, the main goals of the pilot project grant program is to foster innovative measurement of social, behavioral, and economic aspects of the COVID-19 pandemic. and is really intended to support increased collaboration among researchers, and that's both within the consortium and with external researchers, and also to research the pandemic's impact on health disparities in vulnerable populations, and to actually engage researchers from underrepresented groups. As I mentioned, we just recently posted the call for proposals, and can be found on the Coordinating Center webpage. Megan, do you mind putting that in the chat? I'm not sure if that'll go out to everybody, but we can make sure we get you an actual link to that. We're doing things a little bit differently this year. We received an administrative supplement from NIH, which allowed us to increase the number and the size of the grants that we're able to offer. And so this year, we're essentially offering two different sizes. So larger projects up to $60,000 in total costs, and then smaller projects, which is up to $30,000 in direct costs. As you can see kind of over on the right, we have some key dates, the first of which being, when we would like, any letters of intent. I do want to emphasize they are not required, but it does just kind of give us a better idea of the number and the types of applications we can expect to receive, which just kind of helps us plan a bit better and more efficiently for review. We anticipate with kind of this early December 2nd proposal deadline that we will announce awards on December 22nd with an anticipated project start date of March 1st, 2023. And so with that, I really appreciate you guys sticking with us and taking the time to learn about the Coordinating Center and the consortium. And so with that, I'll open the floor to any questions that folks have.
I'm seeing no questions in the chat yet, or in the Q&A yet, but I would encourage people who are watching in feed loop to go ahead and pop those questions into the Q&A. I guess we'll start with a question about what is ICPSR's role in the coordinating center? Will we get the data from some of these projects? I know we already have some of it. Are we just coordinating the meetings and doing the grants? What is ICPSR's role?
Yeah, so that's a really good question. So we are, as you mentioned, we are getting some of the data already, and so we are working with folks to support them in archiving their data, whether it's with us or with someone else, and so that's certainly a big component. But we're also kind of our main role is to facilitate and support the research that these groups are doing, and so one of the ways that we're doing that is providing assistance with data harmonization across different studies and across groups. And that ties in well with the common data elements piece, where we're trying to ensure that we're using consistent measures across these studies so we can kind of get the most bang for our buck, so to speak. And so with these researchers not having plenty on their plates already with doing these projects, that's where we can kind of provide, pick up some of that slack and provide, take care of some of that effort to kind of push forward some of those more coordination tasks that fall outside the scope of the specific projects themselves, if that makes sense.
Great, thanks. We did have one question come in. What do you look for in new COVID consortium members?
So I should just clarify that while we are expecting to grow a bit more, I do believe we're going to be capped right now at 15. I don't believe NIH is going to be putting out another call for UO1 proposals. So those would be the consortium members that we talked about. That doesn't mean that you can't collaborate with consortium members or work with the coordinating center. And kind of the key way to do that would be actually through the pilot process. So you do not have to be a current consortium member to apply for the pilot grant funding. And we would highly encourage external researchers to submit applications.
Great, thank you so much. I do not see any other questions. So barring any last comments from you all, I think we will go ahead and close out the session, and thank everyone for coming to the second last session of the 2022 ICPSR Data Fair. And we hope to see you in the Data Brunch live session at 1 o'clock. So any last words, John or Megan?
Just thank you so much. We're really happy to get to share some of this work with you guys. And yeah, feel free to reach out on the email that was on the page. If you have any questions about the coordinating center or about the pilot grant program, we're always happy to chat.
Thank you so much for a wonderful presentation.
Thank you.
Thank you.